Welcome to Deep Dive Ortho, the show where we extract the essential knowledge you need as mid-senior medical professionals. Today, we're looking closely at something really common, but actually quite deceptive: fingertip injuries. Now, these aren't just, trivial knocks or minor sprains. They genuinely have the potential to profoundly impact a patient's hand function and, well, their whole quality of life. In this deep dive, we'll navigate two specific, highly relevant conditions: mallet finger and jersey finger. We'll peel back the layers on diagnosis, management, and those crucial nuances that really dictate the best long-term outcomes. And perhaps most critically, we'll tackle that often overlooked challenge of preventing joint stiffness. It's a silent complication in hand trauma that can really unravel even the best treatment. Joining me to explore this intricate landscape is Professor Mo Imam, an expert whose insights are always invaluable. So get ready for a thorough discussion, one designed to really sharpen your approach to these challenging everyday injuries. Professor, finger injuries, they're surprisingly prevalent, aren't they? Nearly 40% of all upper extremity injuries presenting to emergency departments in the USA, yet there seems to be this tendency, especially among athletes, to kind of downplay them. Why do you think that happens? And what are the real tangible consequences when these seemingly minor things get overlooked?
That's a profoundly important point, and it really gets to the heart of the issue. Patients, particularly competitive athletes, they often dismiss these injuries. Just simple jams or minor sprains, they think. Their main hope is just a quick return to activity. They're often unaware they might be jeopardizing their long-term hand function, maybe even their career. Think about it: a rugby player grappling, a basketball player reaching. Their fingers are constantly exposed. Direct impact, twisting, sudden hyperextension. The distal phalanx, despite being small, it's incredibly vulnerable. It's exposed. And it plays an absolutely vital role in, well, grip and dexterity, all those fine motor skills.
Right.
And the functional deficits that come from ignoring these injuries, they're far from minor. We're talking about a whole cascade of issues: significantly decreased dexterity, compromised pinch strength. I mean, think about just picking up a coin or doing up a button.
Everyday things.
Exactly. And markedly reduced grasp capability. Beyond the immediate function, there's also persistent pain from, say, unresolved soft tissue injury or the insidious start of post-traumatic arthritis. And we mustn't forget the cosmetic side, that persistent extensor lag where the fingertip stays slightly bent, or a noticeable dorsal bump where bones pulled off. That can be quite distressing for patients.
Yes, I can imagine.
These aren't just aesthetic issues. They truly impact daily life, psychological well-being, and, for athletes, performance, and potentially their whole livelihood. The key insight really is that what seems minor at first glance can have major long-term implications.
That really puts it into perspective. It's about preserving someone's ability to interact with the world properly. Before we dive into mallet and jersey finger specifically, could you maybe give it a quick, high-level reminder of the key anatomy, the DIP and PIP joints? What are the absolute essentials we need to keep in mind here?
Absolutely. A solid anatomical foundation is, well, it's non-negotiable. Let's simplify it to the critical bits. The DIP joint. It typically offers a remarkable range of motion, 0 degrees extension to about 85 degrees flexion. Though its functional posture, interestingly, is around 39 degrees of flexion.
Oh.
Its stability is a delicate balance. It comes from the interplay of extensor and flexor tendons, a thick volar plate, and those stout collateral ligaments. The extensor tendon itself, as it nears the DIP joint, it trifurcates. The central slip goes to the middle phalanx, while the two lateral slips merge with bits from the interosseous and lumbrical muscles, forming the lateral bands. These then cross the DIP joint to insert as the terminal tendon on the dorsal epiphysis of the distal phalanx. What's really fascinating and clinically vital is how close the germinal nail matrix, the bit that grows the nail, is to this insertion.
Right.
On average, it's just 1.2 millimeters distal. That critical closeness, it's a real consideration during treatment, particularly surgery. Even minor damage there can lead to lifelong nail problems.
That's incredibly close.
It is. Then on the flexor side, you've got the flexor digitorum profundus, the FDP. That attaches to the volar metaphysis of the distal phalanx. This tendon gets its blood supply through delicate structures called vincula folds of the mesotenon. The key thing here is understanding this fine balance between flexors and extensors. If that balance gets disrupted, say by an untreated DIP injury causing increased extensor tone at the PIP, well, that can lead to a swan neck deformity.
Ah, yes, the hyperextended PIP and flexed DIP.
Exactly. And that can significantly compromise hand function. That's why early, accurate diagnosis and precise treatment are paramount to stop these secondary problems becoming fixed and really impacting dexterity.
Okay, that's a great refresher. Let's unpack one of the most common ones then. Mallet finger, also known as drop finger or historically baseball finger.
Hmm.
Could you elaborate on its typical mechanisms? And crucially, how do we as clinicians distinguish between the purely tendinous form and the bony version?
Okay, let's get into mallet finger. Fundamentally, it's a traumatic loss of that terminal extensor function at the DIP joint. The classic mechanism, as the name baseball finger suggests, is usually an axial or jamming force on the fingertip, while the DIP joint is actively extending. Imagine catching a ball, and it forcibly flexes that extended fingertip, sort of snaps it downwards.
Right.
This action forces the DIP into acute flexion, and it results in an avulsion, a pulling off of the extensor tendon from its insertion on the distal phalanx. Less often, it can come from hyperextension injuries or even sharp cuts that sever the tendon directly. And you're right, it's incredibly common in contact sports, football, basketball, baseball, where direct finger impacts happen all the time.
And how does it typically present?
Clinically, it's usually quite distinct. Patients present with a painful or sometimes surprisingly painless deformity of the fingertip. They just can't actively extend that DIP joint. The distal phalanx looks dropped or prominently flexed. While the clinical exam is key, it must always be paired with a lateral x-ray. Always. This imaging is vital, not just to confirm the diagnosis, but more importantly, to see if there's a bony bit involved. This differentiation, purely tendinous versus a bony avulsion, where a fragment of bone comes off with the tendon that's the fundamental fork in a road for guiding treatment.
Given those variations, how are mallet finger injuries usually classified? And perhaps more importantly, how do these classifications actually influence our real-world clinical decisions, especially since you mentioned their value is sometimes debated?
You've hit on a key point there about the classifications. There are several systems, yes, trying to provide a framework. For bony mallets, one common one is by Wiebe and Schneider. It looks at articular congruence, how well the joint surfaces line up, and the fracture fragment size, using 1/3 and 2/3 as cutoffs. Then for chronic ones, there's the Burton classification, which assesses the flexibility of the deformities. It's supple, fixed, complicated by fibrosis. But the real insight here is that their clinical value is still widely debated among hand surgeons. They don't always perfectly account for individual patient factors like pre-existing arthritis, which can really influence baseline function and outcomes. And sometimes they miss that subtle difference between a true fracture fragment part of the joint surface and just a tiny flick of bone pulled off the tendon, which might act more like a soft tissue injury clinically.
I see. So they're a guide, but not the whole picture.
Exactly. We use them as a guide, a common language, but clinical judgment and patient-specific factors often trump rigid adherence, especially given the DIP joint's remarkable ability to remodel. The key takeaway is always integrate the classification with the patient's unique presentation and functional goals.
That's a strong argument for a tailored approach. Now, thankfully, many mallet fingers are treated non-operatively. What are the key principles of this conservative management, and what factors really impact its success, especially compliance?
Indeed, conservative treatment is the mainstay for most soft tissue mallets, and for bony ones with less than, say, 30% articular involvement and no volar subluxation. The core principle is continuous splint immobilization. The DIP joint needs to be held in neutral or slight hyperextension. This position keeps the torn tendon ends, or the bone fragment, nicely approximated for healing. Typically, it's 8 to 12 weeks for tendinous injuries, maybe 6 to 8 weeks for bony ones.
And the PIP joint?
Critically, the PIP joint is generally not immobilized. Studies consistently show it makes no difference to tendon gapping at the DIP, so we avoid immobilizing it to prevent needless stiffness. Common splints are stack splints, dorsal alumifoam splints, or those custom thermoplastic ones the hand therapists make.
And success hinges on?
Unequivocally, patient compliance. It's the critical factor. The splint must be worn 24 hours a day. Patients need absolutely crystal clear instructions on safe removal for hygiene, making sure the DIP joint never drops into flexion, not even for a second.
That sounds challenging.
It is. Complications like skin maceration, blisters, recurrence of the deformity, or developing a swan neck. They're often a direct result of poor compliance. It's vital to educate patients up front. Tell them they might have a persistent dorsal bump or even a slight extensor lag afterwards. Managing expectations is key. Just 0.5 millimeter of lengthening in that healing tendon can mean a 10-degree lag.
Wow.
Realistic expectations manage anxiety and really improve adherence. And our hand therapy colleagues, They're absolutely crucial here. Their practical advice on living with the splint day-to-day, showering, sleeping, managing it massively boosts compliance and success rates.
That unwavering commitment from the patient is clearly essential. So, when does operative treatment actually become necessary for mallet finger? What are the main surgical options, and what are the specific risks we need to discuss?
Traditionally, the main indication for considering surgery has been significant articular involvement, say, greater than 30% combined with full or subluxation of the distal phalanx. However, it's worth remembering that acceptable outcomes can sometimes still be achieved non-operatively even in these cases because the DIP joint remodels remarkably well.
So, it's not always clear cut.
No, the decision often hinges on patient factors: age, hand dominance, their sport, position, timing in the season, athletic goals. Is full extension absolutely critical, like for an index finger in a musician? That might push towards surgery. Open injuries, like lacerations, also generally need surgical management, irrigation, debridement. Direct suture might not always be strictly needed, but it's often done.
And the techniques themselves.
For reducible injuries, closed reduction with percutaneous pinning is often a good option. It's simple, cost-effective, less morbid than open surgery. Variants like extension block pinning or retrograde pinning exist. Open treatment might be considered if you feel the benefits of perfect anatomical healing outweigh the risks. It could offer better active motion or cosmesis. This usually means a dorsal incision, exposing the joint, maybe releasing a bit of the collateral ligaments, then fixation with fine K-wires.
But more risks.
Yes, open procedures inherently carry greater risks. Nail growth deformity, more scarring, infection. There's always a trade-off. Simple pinning is less invasive, but open surgery aims for more precise correction, which might matter for high-demand patients. A recent study, for instance, compared hook plates versus extension block pinning. No real difference in pain or lag, but the hook plate was much pricier and needed more dissection. You always have to weigh that benefit versus morbidity.
That makes the decision process quite nuanced. What about those chronic mallet fingers, the ones presenting months later? What are the options then, and how successful can we really be?
Chronic mallets, yes, presenting several months post-injury. They pose a different, often tougher challenge. Tissues have fibrosed, contracted. Treatment options depend on the flexibility, the deformity, and the patient's goals. You could try prolonged extension splinting again. Sometimes it still helps, surprisingly. Surgically, options might include tenodermodesis, shortening the tendon and anchoring it to the skin, or a central slip tenotomy to rebalance things. If they develop a flexible swan neck deformity, maybe from a related palmar plate injury, then an USRL reconstruction spiral oblique retinacular ligament can work well.
Using graft.
Yes, often palmaris longus or extensor digiti quinti. You tension it, so passive PIP extension causes passive DIP extension, a dynamic tenodesis effect. If the DIP joint gets painful, arthritic, or swan neck becomes fixed, then more definitive things like DIP joint fusion, maybe with palmar plate repair, might be needed. Fusion gives stability and pain relief, but no motion.
And can pinning still work late?
In our experience, yes, even up to 24 weeks out, closed reduction with extension block pinning can still be successful sometimes. The tissues retain some healing capacity. Success really depends on tissue quality and, again, patient commitment to rehab.
Professor, taking all this into account, acute versus chronic, patient demands, techniques, what's your preferred overall approach to managing mallet finger in your practice?
My preferred path for acute closed soft tissue or congruent bony mallets is consistent splinting, managed meticulously by our hand therapy team. Why? Because non-op management is proven safe and predictable for most patients, avoiding invasive procedures and risks.
Makes sense.
For open injuries like lacerations, surgery might be needed. For simple cuts, I might do a tenodermodesis, then treat it essentially as a closed injury with careful splinting. For closed bony injuries, if the joint's congruent, I honestly don't fixate too much on the exact size or displacement of the fragment. That joint's remodeling capacity is impressive.
And if it's incongruent?
I'll still trial splinting first, often with a slight bit of flexion. That can frequently restore congruence and avoid surgery. If incongruence persists, then depending on the patient's functional demands, a pro musician versus someone less reliant on fine fingertip control and any pre-existing arthritis, we have a very careful discussion. Shared decision-making. For patients with really high demands or a true dislocation, I tend to favor a simple transarticular wire.
Why that specifically?
It keeps the pin-skin interface well away from the injury zone, reducing deep infection risk, and gives good stability. Look, the literature doesn't definitively say one treatment is best for these complex cases. So my practice is always about getting a predictable functional result with the least risk of complications for that specific patient.
Right, let's pivot now. Having covered mallet fingers so thoroughly, let's shift to another injury that often sounds quite dramatic, jersey finger. Can you describe its typical mechanism and clinical presentation?
It absolutely does sound dramatic,
Yeah.
and the name jersey finger comes straight from that classic mechanism. It's forced hyperextension of the DIP joint while the finger is actively flexed. Picture that rugby or football player grabbing an opponent's jersey, and the opponent pulls away forcefully, rips the tendon right off its attachment.
Ouch.
It's technically a zone I flexor tendon injury, an avulsion of the flexor digitorum profundus, the FDP tendon, from its insertion on the distal phalanx. It can be purely tendinous or involve a bony fragment pulled off. And the ring finger is most commonly affected about 75% of cases,
Why the ring finger?
likely because it protrudes furthest in a grasp, and it's uniquely tethered by bipinnate lumbricals on both sides, making it especially vulnerable to that hyperextension force during a strong pull.
And clinically, what's the giveaway?
The key finding is stark: inability to actively flex the DIP joint of that finger. You can test it easily, hold their PIP joint straight, and ask them to bend just the tip. They can't. They can still flex the PIP and MCP joints thanks to the intact FDS and lumbricals, but that profundus function at the DIP is gone. You might also find point tenderness or swelling along the volar side. Sometimes you can even feel the retracted tendon as a tender lump. If there's bone involved, an X-ray might show the fragment pulled back proximally.
This definitely sounds like one needing immediate attention. How does the Letty and Packer classification help us here in understanding severity and prognosis?
Accurate early diagnosis is absolutely critical. Delays can lead to irreparable fibrosis, scarring in the tendon sheath, makes repair much harder, sometimes impossible. The Letty and Packer classification is invaluable here. For both prognosis and guiding therapy, it divides injuries into three main types based on how far the tendon retracts and, crucially, whether the vincula, those blood supply vessels, are preserved.
Okay, the three types.
Type Y is the most severe. Tendon retracts right into the palm. Both long and short vincula are ruptured, compromising blood supply badly. Prognosis is worse if not repaired quickly, within maybe 7 to 10 days, because the tendon contracts and loses viability.
Right, the clock is ticking.
Definitely. Type 2 is the most common. Tendon retracts only to the PIP joint. Importantly, the long vinculum is preserved, maintaining blood supply. This allows successful repair even a few months later, giving a bigger window. And type 3 involves a large bony fragment avulsing off. Here, the distal pulley mechanism usually stops the tendon retracting beyond the middle phalanx. Understanding these types helps us gauge urgency and predict outcomes.
Beyond the exam and x-rays, which are great for bony bits, how have things like ultrasound and MRI changed pre-op planning, especially for those purely tendinous injuries?
They become increasingly popular and incredibly valuable. X-rays confirm bony avulsions, sure, but they don't tell you much about purely tendinous injuries or the exact retraction level. That's where ultrasound and MRI shine. They give a much more accurate pre-op picture of exactly where that tendon end is, especially without a bone fragment.
So fewer surprises in theater.
Precisely. This detailed mapping limits intraoperative surprises, allows better planning, minimizes the dissection needed to find the tendon, which means less morbidity for the patient, less scarring, less tissue damage. Plus, they can help differentiate jersey finger from less common, zone 2 or 3 intertendinous FDP ruptures, which can look similar clinically but need a different surgical approach. It turns planning from an educated guess into a precise roadmap.
Let's talk operative treatment then. What are the main surgical techniques used, and how do they stack up in terms of outcomes and risks we need to discuss with patients?
Right. Almost all acute jersey fingers in athletes need surgery. Most surgeons advocate repair ASA to prevent tendon contracture and fibrosis complicating things later.
Okay.
Several techniques have evolved. The Bunnell pull-out suture was traditional. Sutures go through the tendon, out through the bone with needles, tied over a button on the nail dorsally.
Sounds effective, but risky.
It can be effective, yes, but carries risks.
Yeah.
Infection at the suture site, skin necrosis under the button, nail bed injury for the needles. So suture anchor repair came along to avoid that external hardware. A small anchor goes into the bone, sutures from it repair the tendon. But anchors have their own risks, potential nail bed issues, joint penetration. Interestingly, lab studies show incorporating the volar plate into the anchor repair can significantly improve strength, decrease gapping, makes more robust repair.
Any newer techniques?
Yes. A more recent one by Alcatan involves reattaching the profundus directly to a distally based volar plate flap end to end. It offers simplicity, good repair strength, encouraging early results. Despite theoretical worries about DIP joint hyperextension instability, which seem mitigated by other structures. The takeaway is the balance. Each technique has pros and cons. Choice often depends on surgeon preference, the injury specifics, resources available, always weighing benefit against risk.
The concept of wide-awake surgery is fascinating. How has this approach, particularly popularized by Lalonde, influenced flexor tendon repairs like jersey finger?
Wide-awake flexor tendon surgery, using local anesthetic with adrenaline, no tourniquet. It really is a game changer, especially for zone 1 and 2 injuries like this. Its key advantage, the revolutionary part, is assessing the repair intraoperatively. You ask the patient to actively flex the repaired tendon right there on the table.
Real-time feedback.
Exactly. Optimal real-time feedback on tendon translation, gliding, tension. This is crucial for preventing complications like quadriga, where advancing a contracted FTP limits flexion in adjacent fingers. By having the patient flex during the procedure, the surgeon can fine-tune tension, ensure smooth gliding, significantly reducing post-op adhesion risk, and aiming for the best functional outcome. It turns repair from static reconstruction into a dynamic, interactive process. More predictable results.
And for those chronic jersey finger injuries presenting weeks or months later, maybe after that ideal window, what are the treatment considerations then?
Right. Injuries presenting maybe 4 to 6 weeks after, generally considered chronic. Delayed primary repair might still be possible, especially for type 2 or 3, where viability is often better preserved. But if the tendons retracted significantly, can't be brought back, or if the main issue is lost dexterity rather than pain or instability, and the DIP joint is still supple, staged FTP reconstruction might be an option, using tendon graft.
And if the joint itself is the problem?
If it's become painful, unstable, arthritic due to the chronic injury, then DIP joint arthrodesis fusion might be considered. Provides a stable, pain-free digit, but sacrifices motion at that joint. It's also important to remember FTP repair isn't always essential for everyone. Some function quite well with just superficialis flexion at the PIP, especially if functional demands aren't high or they can't commit to the intense rehab. The decision is always tailored. Patient needs, expectations, prioritizing function and pain relief.
Professor, weighing all that acute urgency, chronic challenges, techniques, what's your preferred approach for jersey finger in your practice?
My preference for acute jersey finger injuries, particularly in athletes, is the pull-out suture technique. Now, while it has inherent risks, as we discussed infection, nail bed issues, excellent outcomes are achievable when both the surgical technique and the post-op rehab are meticulously executed. Precision in placement, secure anchoring, coupled with a well-managed, immediate rehab protocol. That's key. Non-surgical treatment. Generally reserved for chronic cases where repair isn't feasible anymore due to tendon issues or for patients simply unable or unwilling to comply with the strenuous, prolonged rehab flexor tendon repairs demand.
So surgery is usually the way for acute cases.
It must be stressed, yes. For optimal return of function in an acute jersey finger, surgical intervention is almost universally required. The crucial insight is, ignoring this acutely is almost certainly going to lead to long-term disability and significant functional compromise.
That brings us neatly to a really crucial yet often frustrating area. Joint stiffness after hand injuries. You've made a rather provocative statement suggesting stiffness is often iatrogenic caused by our treatment. Can you elaborate on that?
It's a statement that needs to resonate, really. Because patients often say, quite rightly, "Doctor, I came to you with a break or a tendon injury, but I didn't come with a stiff joint." It highlights that stiffness often can be a direct consequence of our treatment approach or aspects of it, rather than solely the initial injury itself, unless, of course, the joint surface was severely damaged directly, like an articular fracture.
So it implies a responsibility on our part.
Absolutely. A significant responsibility to actively prevent it. It's not just an unfortunate complication, it's something we often have a direct hand in controlling. The core insight is, our necessary interventions carry this hidden risk of inducing stiffness if not managed meticulously.
So if we bear this responsibility, what are the core principles? You mentioned a trifecta for actively preventing this iatrogenic stiffness.
Yes, the prevention truly hinges on a critical trifecta. First, actively avoiding tissue edema. Second, meticulously decreasing inflammation. And third, immobilizing the joint in the correct position for the shortest effective period. All three need addressing together.
Let's break those down. Edema first.
Avoiding tissue edema is paramount. A hand at rest should always be elevated above the axillary level. Gravity works against you, otherwise fluid pools, slings, almost always avoid them entirely. They usually put the hand below heart level, counterproductive for edema. When the hand isn't moving, elevation is key. On a pillow, on a table, whatever works. For fingers, a compression bandage can be great, especially for round structures. Helps manage edema while still allowing some mobility, which is crucial early on.
Okay, edema control, then inflammation.
Next, decreasing inflammation. Now, inflammation is needed for initial healing, yes, but excessive or prolonged inflammation causes fibrosis, and fibrosis is a direct precursor to stiffness. We consistently see joints surrounded by significant inflammation stiffen much faster. Think about immobilizing an injured elbow versus a healthy one for the same time. The injured one stiffens more due to that accelerated collagen deposition around the capsule. Fibroblasts are the culprits, releasing excessive collagen fibers. Administering steroids post-trauma or surgery can really help. They close capillary pores, reducing inflammation, limiting edema, and crucially, decreasing the migration of those collagen-producing fibroblasts into the tissue.
Right, dampen down that response.
Exactly. Finally, once edema is controlled and inflammation minimized, you can't eliminate it, but you reduce it. Then, immobilizing the joint in the correct position is vital. This is about preventing ligaments, capsules, even skin from shortening in positions that make future movement difficult or impossible.
That leads perfectly to the protective position or safe position. Can you explain what that actually entails for the hand and fingers and why it's so critical?
Right. The hand can adopt a rest position, or, more accurately after injury, a traumatic position. The traumatic position is the one we must always avoid. That's forearm pronated, wrist flexed, often from gravity, and crucially, MP joints held in extension. When the MPs are extended, edema on the back of the hand pulls the dorsal skin taut, forcing MPs into more extension, which then paradoxically makes the PIPs and DIPs flex even more, a cascade of stiffness.
So what is the protective position?
For immobilization, we strive for the protective position, also called the safe position or principles position. This is the specific setup to prevent stiffness and maximize future function. In order of importance. First, the interphalangeal IP joints, PIP and DIP, must be in full extension, exactly 0 degrees. Even 5 or 20 degrees of flexion risks stiffness, and IP stiffness is notoriously hard to treat. Second, the metacarpophalangeal MP joints should be immobilized in flexion, ideally around 70 degrees, though there's some tolerance. MP stiffness is easier to treat if it occurs in extension, so flexion is protective. Third, the thumb needs to be separated, abducted from the index finger for optimal opposition later. And finally, the carpal and metacarpal joints of the ring and small fingers should be flexed. Important because normal function, like using tools, needs flexion and supination there. Stiffness and extension would severely limit that.
That's a fascinating breakdown. What's the anatomical why behind those specific positions being protective?
This is where it gets really interesting, understanding the mechanics. For MP joints, it's about the collateral ligaments. They're relaxed in extension, but taut in flexion because the metacarpal head is wider volarly, cam-shaped. Immobilize an MP in extension. Those ligaments stay short, get encased in collagen, become almost impossible to stretch later. Immobilize in flexion. Ligaments stay taut, stretched, preventing shortening. Crucially, the MP volar plate isn't attached proximally like the PIPs, so volar plate fibrosis isn't the issue in flexion here. That's why MPs rarely get stiff from the joint itself, even after prolonged flexion. Like in Dupuytren's, it's usually surrounding tissues.
And the PIP joints are different.
Completely different story. For PIP joints, the collateral ligaments don't change length much between flexion and extension due to the condyle shape. So they aren't the primary cause of PIP stiffness. The real culprit at the PIP is the volar plate, especially its membranous proximal part, the arcate ligament. This ligament folds on itself in flexion. Immobilize the PIP in flexion for too long, especially with fibrosis from injury. That arcate ligament stiffens, shortens, literally blocking extension.
So full extension is key for the PIP volar plate.
Absolutely key to prevent that shortening. Then we also need to consider the skin. Dorsal finger skin is thin, mobile, but volar skin folds and shortens much more when the PIP flexes. Skin-retaining ligaments, quilins, Graysons connect skin to bone or sheath. They can also pathologically shorten, contributing to contractures. This explains the dermodesis effect. Extend the MP joint, and shortened volar skin can pull the PIP into unwanted flexion. I treated a woman once. PIP extended fine in surgery, but post-splinting it kept flexing when she extended her MP. Took a while to realize the problem was severe skin shortening, maybe 13 millimeter.
Incredible.
That's why a Z-plasty at the finger base, where there's more skin, can be vital for chronic PIP flexion contractures to lengthen that skin. And remember, the PIP joint itself will never become stiff in full extension from capsular pathology. The capsule is thin, extensor tendon mobile. If you see PIP limitation inflection or stiffness inflection, it's almost always problems with the extensor apparatus or intrinsic muscle contractures, pulling the PIP into extension.
And you test for that intrinsic tightness.
By putting the MP joint in full extension. If PIP flexion becomes even harder, that points strongly to intrinsic muscle contracture.
That's a fantastic diagnostic tip. This leads to a critical point about pain. How does pain influence stiffness development, and what are the implications for management, especially regarding surgery?
Right. This is where it gets really interesting and often missed. Pain is arguably the worst thing for stiffness in an injured joint. Even a minor sprain, if consistently painful, is highly likely to stiffen over time. Think about a Charcot joint severe destruction, but rarely stiff because there's no pain signaling the brain to guard it.
So the body's guarding response is the enemy.
Exactly. The natural response to pain is guarding, involuntary immobilization. That chronic guarding, plus persistent inflammation, creates the perfect storm for fibrosis and stiffness. The implication for management is profound. You must treat the pain first. I would personally never operate on an interphalangeal joint if it's painful. We need to eliminate the pain often through proper immobilization, analgesics, before considering surgery to restore motion. Once pain subsides, the biological environment is better, surgical outcomes are far more predictable and successful, no pain-induced guarding fighting you. The crucial insight: ensure the body's protective pain response doesn't lead to long-term functional deficit, like a fixed contracture. Address pain, then mechanics. Non-negotiable sequence.
That's a powerful principle. Okay, beyond mallet and jersey fingers, what other jam injuries should clinicians be particularly aware of, especially at the PIP joint, which you said is the most common site in sports? Maybe a quick overview of other key ones?
Vital question, yes. Jam injury is a broad term covering a spectrum of specific traumas. And you're right, the PIP joint is the most common digital injury site in sports. Exposed, critical for grip. So at the PIP joint, we often see collateral ligament injuries, usually from radial or ulnar forces causing rapid sideways deviation. Common in the right index fingers radial collateral in football, for example, clinically. Focal pain, swelling, bruising on the side. Lateral instability on stress testing, flex PIP to 30 degrees, apply stress, opens 10 degrees compared to the other side. Indicates a tear. Most stable ones are managed non-op, rigid splinting for 3 weeks. Athletes often play with buddy taping, though grip might be compromised. Untreated cases risk chronic pain, instability, even degeneration later.
What else is common?
Volar plate injuries, caused by hyperextension, common in ball handling sports. Ball hits extended finger, ranges from sprains to tears, sometimes with a bony avulsion. Diagnosis involves checking for volar laxity with dorsal pressure, no firm endpoint and extension. Isolated avulsions without instability usually respond well to early mobilization, progressive ROM exercises, starting about a week post-injury. Crucial to prevent flexion contractures. Surgery is usually reserved for unstable ones, avulsion of 40% of the joint surface. Needs open reduction, reattachment. Then there are central slip and boutonniere injuries, usually from rapid force PIP flexion, common in basketball. Can be tendon rupture or dorsal avulsion fracture, maybe with volar PIP dislocation. The Elson test is key. PIP extends via lateral bands. DIP becomes rigid or hyperextended. Points to central slip injury. Most central slip tears are treated non-surgically. Rigid PIP extension splinting for 6 weeks, allowing full DIP motion. Aim is to prevent progression to a fixed boutonniere deformity PIP flexion, DIP hyperextension, which can happen fast, 2-3 weeks if untreated.
It's clear even within jam injuries, there's a huge spectrum. What about dislocations and fracture dislocations? And what are pulley ruptures?
Indeed, lots of variability. PIP joint dislocations are categorized by direction: dorsal, lateral, volar. Dorsal most common, linked to hyperextension, volar plate damage. Volar less common, may involve central slip damage. Simple traction often reduces them, especially before swelling sets in. But volar rotatory dislocations are trickier, sometimes need open reduction. K-wires due to soft tissue entrapment, condyle gets stuck. Crucially, reduction doesn't mean you're done. Needs post-game evaluation, splinting to prevent redislocation. But avoid prolonged rigid splinting beyond 3 weeks because of stiffness risk. Fracture dislocations of the PIP, complex, high-force injuries, often need immediate evaluation by a hand surgeon, inherently unstable, high risk of long-term problem.
And pulleys.
Pulley ruptures, relatively uncommon but highly specific, seen in athletes using a crimping, grip, rock climbers, baseball pitchers. A2 and A4 pulleys in middle and ring fingers most affected due to huge stress. Patients often report a pop, then pain, swelling, sometimes visible bowstringing, if multiple sequential pulleys rupture tendon lifts off the bone.
How are they treated?
Most isolated ruptures. Non-surgical. Rest, pulley ring splinting, anti-inflammatories. Steroid injections discouraged can delay healing. Reconstruction considered for multiple ruptures to restore mechanics. Rehab involves early active passive tendon gliding. Full return to sport usually 2–3 months. Some climbers use protective taping indefinitely, though evidence for preventing re-injury isn't definitive. Key is understanding those specific high-demand mechanisms.
For our mid-senior professionals listening, getting athletes back to play safely is paramount. What are the general principles for managing athletes with these finger injuries, and how vital is the hand therapist's role?
The overarching aim, yes, is always safe, timely return to play. For mallet and jersey finger, if surgery was needed, athletes typically face 8–12 weeks at a competition. But the decision isn't just about time. It's about hitting key functional milestones. Need functional active range of motion, minimal to no pain during sport-specific activity, and grip strength over 80% compared to the uninjured side. Ensures the hand isn't just healed on paper, but truly ready.
And the hand therapist role.
Absolutely indispensable. Truly the unsung heroes of hand rehab. They do a detailed demand needs analysis. What specific movements, forces, grips does this athlete need for their sport and position? Then they tailor a highly specific progressive rehab program. Targeted tests, exercises simulating sport-specific movements, building resilience. Ensures the hand is functionally prepared for those unique demands. This bespoke approach lets us surgeons more confidently clear them for competition, minimizes re-injury risk, ensures optimal long-term function. Without their specialized expertise, achieving that functional readiness would be incredibly hard, our outcomes far less predictable.
Professor, this deep dive has been incredibly insightful, really revealed the hidden complexities in seemingly simple finger injuries, and underscored the impact of meticulous, patient-centered management. What final provocative thought would you like to leave our audience with? Something for them to mull over.
What's fascinating, really, is that despite this array of intricate, splinting, and surgical techniques, the literature doesn't always definitively crown one treatment king over another for all these injuries. Conservative methods for many mallet injuries, for instance, consistently proven safe and predictable for most, often avoiding invasive procedures. I'd urge you to remember, the mechanism of injury almost always provides the most crucial clue for effective treatment. Understanding how it happened often guides the most appropriate what for your intervention. The ultimate goal isn't just healing anatomy, but restoring predictable function with the least risk of complications. Always prioritize understanding the how behind the injury. It guides the what of your treatment, leading to better outcomes, more satisfied patients.
And that brings us to the end of another enlightening deep dive. Thank you, Professor Moimam, for so generously sharing your invaluable expertise and illuminating the intricacies of fingertip injuries. Your insights truly offer a shortcut to being well-informed. If you found this discussion as engaging and informative as I did, please consider rating and sharing this deep dive with your colleagues. It really helps us reach more medical professionals like you. Join us next time on Deep Dive Ortho, where we continue to extract the most important nuggets of knowledge from the vast world of orthopedic medicine. Until then, keep learning and keep exploring.